Hi guys, welcome back. The topic we're studying is meningitis. I will initially talk about bacterial meningitis, which would be having a turbid CSF with neutrophils, and we'll be discussing etiology-based data here. So I'm going to describe why a newborn baby would be developing a neonatal meningitis and which is the organism responsible. Well, the infection would come to the baby from the female genital tract, and on a global basis, the number one answer would be given as group B streptococcus, which is alternatively also written as Streptococcus agalactiae. The controversies, however, for organism for India, so I don't want you to bother for this information that I'm writing now, because obviously you will say that the pediatrician said an X organism, you are saying a different one, and maybe the microbiologist said something different. Well, the studies in India are mainly focused or limited to only few hospitals, and most of the consensus studies in India have been regarding Klebsiella, then about Acinetobacter, and subsequently about E. coli. And I know the controversy that you will say that in some subjects we have been taught about E. coli also, but it really does not matter, because what they ask you is usually the global basis. They will definitely be interested in you knowing regarding a rare cause of bacterial meningitis in newborn babies, that is Listeria monocytogenes. And why is that important is because this particular organism does not exhibit sensitivity to third generation cephalosporins. Shocking, no? I mean, normally whenever we are using third generation cephalosporins in meningitis, we get a very good clearance of the bacteria from the CSF and the patient begins to recover. In fact, in neonatal meningitis, we use cefotaxime. We usually don't use ceftriaxone in newborn babies because of higher incidence of jaundice. So cefotaxime is usually used, but in this case, you will notice that lots of time the pediatrician, because he may not get a microbiological confirmation, so he might be empirically using two antibiotics. One is obviously cefotaxime for treating group B streptococcus, but along with this he will also be using ampicillin, and that is precisely the reason why this has been asked in your exam per se. The question mentioned regarding Listeria monocytogenes, and he said that this baby whose CSF culture has showed Listeria monocytogenes will be now therapeutically started on which antibiotic. The answer is ampicillin. I mean, the surprising thing is that normally you always have sensitivity to third generation cephalosporins, but in this case you would be having sensitivity to ampicillin. Let us now move up the ladder to a child, and if he says what is the leading cause of meningitis in a child, the answer will be given as pneumococcus and not Haemophilus influenzae. The reason for that is that due to the Haemophilus influenzae vaccination, casually called as HIP vaccine, taking up on a global basis, both in India, upper socio-economic strata of the society, at least it is given. Government of India is also trying to incorporate it, and on a global basis, anyway, the push for HIP vaccine is there. So the incidence of Haemophilus influenzae has reduced dramatically. So why would you answer Haemophilus influenzae in some of the MCQs is because this infection definitely causes production of pus in the meninges, but has predilection for development of pus around the 8th nerve. Now, when you will give antibiotics, obviously the pus is going to disappear, patient will recover, but unfortunately, because there was substantial amount of damage around the 8th nerve, there's going to be gliosis of the 8th nerve. So the bad news in this case is that this particular kid could actually become deaf, and that is why in a question that even the ENT doctor will talk about, post meningitis deafness, if specified in the question, if he says a child who had recovered from meningitis has subsequently become deaf, then you need to answer as Haemophilus influenzae. Otherwise, incidence wise, the primary answer will be given as pneumococcus. Yeah, the same organism which causes community acquired pneumonia in children is also the leading cause of why a bacterial meningitis would be occurring. Now we come to adult population, and here the specific thing I want you to be very clear about is again that pneumococcus is the leading cause. When I describe it, a lot of guys say, sir, why not Neisseria meningitidis? Because when you talk about pneumococcus per se, it is written that it is the leading cause of sporadic meningitis, whereas in the winter months in our country, you see, winter in India is only gonna be few days of December and then January, and then it's back to spring and summers once again. So, I mean, winters are very short duration in India. That is where we read about Neisseria meningitidis. We read about epidemics of Neisseria meningitidis on an annual basis, primarily related to overcrowding. You see, Neisseria meningitidis per se is reported in the media in the winter months. There's going to be epidemic, especially with situations like urban slum. There's going to be 5 members living in a shanty in a small house, and all of them have developed meningitis. So when he talks about, let me say, our entire floor of the hostel had to be vacated because everybody living on that floor of the hostel suffered from meningitis. Or he talks about military barracks. That barracks had to be vacated because the military recruits simultaneously developed meningitis, or like I talked about, low socioeconomic state of the society, people coming from urban slum from the same family or extended family. That is when you have to think in terms of Neisseria meningitidis. Now, my point is, guys, that when it comes to the epidemics of meningitis per se, you see, the cases are gonna be admitted for only few months per year. But when it comes to pneumococcus, it's gonna be like one case today, zero case tomorrow, maybe three cases tomorrow. All around the year admission is mainly with pneumococcus, whereas only for a few months of a year is Neisseria meningitidis. So when we look at the numbers, you will notice the pneumococcus is relatively the more common cause as compared to Neisseria meningitidis. Yes, pneumococcus is answer to 4 MCQs at the moment. Pediatric pneumonia, adult pneumonia, that is community acquired, pediatric meningitis, and even adult bacterial meningitis is caused by pneumococcus. The problem why Neisseria meningitidis is asked more often is primarily because of the route of the spread. It will be easily able to spread via droplets. So even the doctor who's taking care of this person is vulnerable. Once a doctor is gonna get this infection, he can not only develop meningitis, but he can unfortunately even develop sepsis, can then develop disseminated intravascular coagulation. This can contribute to bleeding in the adrenal gland. If the bleeding occurs in the first layer of the gland, it will result in hypotension. If the bleeding occurs in the second layer of the gland, it will contribute to hypoglycemia. So there can be Addisonian crisis that could be developing in this person post Neisseria meningitidis, and that is what is you reading as Waterhouse-Fridson syndrome. In fact, I want you to be very clear about the fact that in Waterhouse-Fridson syndrome, the petechiae and purpura will be extensive fluid all over the body, especially on the lower extremities, because petechiae due to gravity first appear in the lower part of the body. In contrast to dengue, where the manifestations of bleeding occur when the fever is rather resolving. In this patient, even when the fever is there of a short duration, 2-3 days, once the sepsis will come in, septic shock will come in, simultaneously when the septic shock is going on, that is when the patient will start having development of bleeding. Whereas in dengue, the bleeding manifestations usually begin at defervescence. When the fever comes down, that is when the bleeding manifestations will appear. At this junction, I don't want you to mix up the information of Waterhouse-Fridson syndrome with that of Wunderlich syndrome. Now, Wunderlich syndrome is what you read with tuberous sclerosis. Tuberous sclerosis is a neurocutaneous disorder in which there will always be family history of epilepsy. You will be having cutaneous manifestations in the form of presence of, I would say, Sjagren's patch, or even ash leaf macules can be present. And then you have a malformation in the kidney with a very peculiar name where three tissues are present: angiomyolipoma, where there would be blood vessels, there would be muscles, and there would be fat. If a patient of Wunderlich syndrome is having an angiomyolipoma of the kidney, the bad news is that this angio lesion can definitely bleed. So the message is Wunderlich syndrome is related to bleeding in the kidney with respect to tuberous sclerosis per se, whereas Waterhouse-Fridson syndrome is due to the bacterial impact of Neisseria meningitidis. And then his objective would be to ask you that how can you prevent these droplets from spreading? And the answer is definitely, or the solution is definitely not masks. Because per se, even if we are using an N99 mask, there would still be some possibility of spread. So if you wanna prevent the spread, the best way would be to go in for chemoprophylaxis. For chemoprophylaxis, when he says what is the drug that is recommended, then your answer is ceftriaxone. Here your query would be, sir, we have studied in different subjects like PSM, etc. is given rifampicin. I want to highlight that the efficacy of rifampicin is only about 70% and is not recommended for healthcare worker. Because a doctor is vulnerable, we would rather be giving parenteral ceftriaxone to the doctor to prevent his life from obviously being affected. If he mentions regarding a family contact, like husband is sick, wife is taking care, wife is sick, husband is taking care, father is taking care, if it's gonna be a family contact who can definitely also suffer, then for them we will be using fluoroquinolones like ciprofloxacin. Now he can create a scenario like he can say that the wife who is 6 weeks pregnant has been taking care of her husband who has been admitted with Neisseria meningitidis. In these circumstances, because she is expecting, she is in the first trimester, if you give ciprofloxacin, well, teratogenicity can occur. You very well know that quinolones are not recommended in pregnancy, mainly because they interfere with the cartilaginous growth of the child. So in pregnancy, once again, you see, ceftriaxone is the one that is recommended. Though here you might say, why should the wife take care of the husband when she is expecting herself? So I can just put a practical situation. No, it's like a nuclear family. Husband and wife are staying in Delhi and the family is way back in some other state. So obviously for the relatives to come, it will take some time. By the time she is the one who will be taking care, because we at least need one attendant per patient. So in those circumstances, it is recommended that we give ceftriaxone. So overall, the best answer in the exam is not rifampicin, it is ceftriaxone. And if he specifies the word family contact, then great, you can definitely answer ciprofloxacin. So I hope I have tried to resolve this aspect before you. And for adults, I want to highlight once again, pneumococcus will be the leading etiological agent. We are now going to compare this information with that of viral meningitis. So question to you guys up here, when it comes to viral meningitis versus viral encephalitis, can you tell me the organism for viral meningitis from microbiology knowledge, guys? Viral meningitis can have nuchal rigidity, but definitely nuchal rigidity will not be present in a case of viral encephalitis per se. I'm still waiting for your brain to register the correct answer for viral meningitis. Well, you have thought correct, guys. It's gonna be enteroviruses, which is the number one cause of viral meningitis. If he says encephalitis, then the answer will be different from India versus global. Let's have the answer from your side, guys. What's gonna be the global answer? It's gonna be herpes simplex 1, HSV1 encephalitis. Yes, the same organism whose HSV2 version contributes to STD and grouped vesicles on the penis or on the genitalia is responsible for viral encephalitis, where we can definitely be using acyclovir. For India, the organism is Japanese bee encephalitis, right, which is notorious because of Culex mosquito, and also came in the limelight because Dr. Kafil, he was actually heading the Japanese encephalitis ward when unfortunately disaster struck, oxygen supplies ran out, he was arrested, put behind bars. I mean, in India, obviously, nobody gets punished except doctors. No, I mean, politicians are okay, everybody's okay, it's only the doctors who are at fault. Coming back to the main agenda, guys, viral meningitis is enterovirus and viral encephalitis is going to be herpes simplex 1 encephalitis. I want to highlight that there are certain very peculiar points that you need to remember for HSV1. One would be finding of bloody CSF. Now, bloody CSF has also been mentioned a couple of times. So one, I want you to remember, bloody CSF is seen with traumatic lumbar puncture with subarachnoid hemorrhage. And how will you differentiate whether it is due to subarachnoid hemorrhage or traumatic lumbar puncture? You will do a 3-tube test. You will take serial contiguous samples. If it is subarachnoid hemorrhage, all the samples will be diffusely having RBCs or blood present. But if it is due to trauma, because the clot will start developing, so usually by the second or the third tube, the redness or the RBCs in the sample will begin to disappear. I repeat that again. In subarachnoid hemorrhage, the blood is mixed with CSF, so it will be uniformly bloody, or the RBCs in the CSF will be uniformly present in the first sample, second sample, third sample. But in a 3-tube test, when it comes to a traumatic lumbar puncture, as you go towards the third sample, the RBCs are going to disappear. Apart from that, I also want you to remember that per se, when you read about traumatic lumbar puncture contributing to bloody CSF, the source of bleeding in this case has also been asked, that is epidural venous plexus. Lots of time when you would have done a lumbar puncture, you could have done lumbar puncture 100 times in your career, but when you are doing it maybe for 101th time, you are super confident in this blood. Where does the blood come from? Whenever there is going to be bleeding anywhere, this should be a normal reflex for you to always look for the source of bleeding, and the source of bleeding in this case will be the epidural venous plexus. Bloody CSF will also be present in patients of viral encephalitis. So these are 3 important causes which are to be remembered. And yeah, bloody CSF definitely helps you in thinking in terms of this disorder, where there would be a very peculiar manifestation that I will explain. We are not going to wait for the PCR. Like, the best investigation for these patients would be to go in for a PCR, and I would like to do it for HSV1. But I am not going to wait for the report to come. Like, I might have to send the sample to Bengaluru or to Bombay if the facility is not available in my city, and the turnaround time might be in weeks. So we are not going to wait for the report to come. We will straight away start empirical acyclovir in these patients. Then this disease has a very peculiar predilection to affect the temporal lobe, and this will be reflected in the EEG also, and will be reflected in the fact that these patients might even lose their memory. I've explained to you temporal lobe is responsible for integration of various things ranging from smell, taste, and even it integrates the memory because hippocampus is located deep inside, and then you have the neocortex which is projecting. So temporal lobe damage can actually cause this person to lose his memory as well, which is why we are worried about him, and that leads us to a EEG finding. The EEG finding will be showing slowing that would be called as periodic, but this periodic slowing will be present only in the temporal leads because that is where the damage is present. So the term used in EEG is called as PLED, that is periodic lateralized epileptiform discharge. I'll show you the image of the same also, but first I want you to be comfortable with the term, that don't mix it with periodic sharp wave complexes which are going to be seen with variant Creutzfeldt-Jakob disease, that is PSWC. I am talking about PLED, periodic lateralized epileptiform discharge, which is a feature of herpes simplex encephalitis. Ideally, the best way for diagnosis of this condition would be to take up a CSF sample, run a PCR for herpes simplex 1, but obviously it's gonna be dependent on the resources available before you. So the points that I want you to remember mainly are bloody CSF, empirical acyclovir, temporal lobe predilection, and PLED, which is a special EEG finding that I'll explain to you as we progress on the image-based domain in the next slide. I also want you to remember the following facts. Most cases of herpes simplex encephalitis or per se encephalitis might be presenting as an acute psychotic state before you. The history might be only of one day. You see, traditionally in bacterial meningitis, the history is of few days, but here it will be usually shorter duration. Like he might just mention history of this person having high-grade fever for past 1 day, and now he is behaving in a very aggressive fashion, like he is using abusive words. There is violent behavior on the part of the patient. There is aggressive streak on the part of the patient, to the level that he might even behave like a frankly psychotic patient. Now, what I mean by frankly psychotic patient would be a person who's literally hitting his family members. He was a very docile person, but post fever, he's very violent. He's trying to scratch at them, hurt them deliberately. He's making attempts to do that. So the family members are very distressed by that. Along with this, when you were asking him, why are you behaving like this? Maybe you raised your voice a bit, right, to intimidate the patient. No effect, he's totally mum. There would be aphasia, there would be apraxia, because there's definitely cortical damage in encephalitis. And then a very peculiar manifestation is dysregulation of the hypothalamic pituitary axis. You see, one of the important functions of the hypothalamic pituitary axis is temperature regulation. Now this patient could be having a hyperthermia. There would be fever that could be spiking up to 107, 108 degree Fahrenheit, and then HPA axis insufficiency can also trigger diabetes insipidus or syndrome of inappropriate ADH secretion. Obviously not both, one of them, but I want to say at this junction that when you read about the literature of SIADH usually results in development of euvolemic hyponatremia, and that hyponatremia can again contribute to development of seizures in a patient. I also want you to remember that when I've discussed the topic of SIADH, when you go through the kidney section where I've talked about SIADH, diabetes insipidus, psychogenic polydipsia, there in SIADH etiology, I have talked about the viral infection coming up again. I have highlighted CNS infections are one of the important causes of SIADH. I repeat that again. You can go to the SIADH section, guys. I've highlighted CNS infections. It could be encephalitis, it could be brain abscess, but the point is CNS infections can actually manifest as syndrome of inappropriate ADH secretion, primarily because of a hypothalamic pituitary axis insufficiency that would be developing in the patient. And well, before we discuss the EEG findings of this guy, I just want you to remember this term, which is usually written in short, PLED. In the exam, he writes PSWC, periodic sharp wave complexes, that is variant Creutzfeldt-Jakob disease, PLED, periodic lateralized is temporal lobe. which is damaged. So therefore the slowing in the EEG will be seen primarily in the lateral lobes of the brain. So whenever you are having a short duration illness like this, the one that I've highlighted at the moment, first thought process of yours from Indian exam when fever is only for 1 or 2 days can be cerebral malaria. Agreed. But if you are not thinking in terms of cerebral malaria, then the next thing that should definitely be on your mind is encephalitis. So these are two differentials which are always to be remembered for a febrile state followed by altered sensorium developing in a patient. Please remember the fact that altered sensorium may not be present in a meningitis case. Meningitis, the triad will be that of fever with headache with nuchal rigidity. Altered sensorium may not be present because altered sensorium, if it occurs in meningitis, it is secondary to raised ICT. Per se, when you look at the disease process of meningitis, the triad that I'm saying, though the triad may be present only in 40% cases, the triad of meningitis at the moment I'm saying verbally is fever, headache, nuchal rigidity. Altered sensorium is not included in the triad. If the question begins by altered sensorium and short duration illness of 1 day, don't think in terms of meningitis, think in terms of what I just highlighted before you, cerebral malaria, and then you have to think in terms of viral encephalitis. And obviously for malaria, we have a dipstick available, that is HRP2 dipstick, histidine rich protein 2 dipstick. We can do a peripheral smear examination, and we can definitely start even empirical artesunate in a patient, especially if a patient has come from rural part of the country. So let us revise the EEG findings once again, though they're discussed in epilepsy topic. Periodic sharp wave complexes that would be encountered with variant Creutzfeldt-Jakob disease. I'm introducing a question for you guys, would help you recall and assess yourself, because this is discussed in epilepsy chapter. Let us see how much do you remember. Burst suppression pattern in EEG. This patient had suffered from cardiac arrest. You had started CPR within the first 4 minutes and a successful CPR was given, and following a successful CPR, the EEG of the patient is showing a burst suppression pattern. This burst suppression pattern is what is seen with deficiency of oxygen delivery to the brain. It is seen with anoxic cerebral injury. So this pattern will usually be seen in patients post resuscitation. And then, as I've highlighted a couple of times, PLED, periodic lateralized epileptiform discharge. This is a feature that is suggestive of herpes simplex 1 encephalitis. In fact, in the EEG discharge that is currently on the monitor on the slide before you, I want to highlight that it's mainly the temporal leads where this discharge is present. So that's why I was saying the word lateralized, because temporal lobes are on the side. The best way for confirmation of this medical condition that I've explained to you, I'll just put a fifth point here. The investigation of choice for encephalitis is PCR HSV, but as I highlighted, do not wait for the report to come and then initial treatment. Empirical acyclovir can also be started. I'll give you some more scenarios which are to be remembered before we go forward. Since I was talking about herpes per se, if I give you a question that mentions grouped vesicles which are present either on the vulva of a sex worker or on the glans penis of the client who visited the sex worker, then grouped vesicles on glans penis is a feature of herpes simplex, that is HSV2. You are very well aware HSV1, one number is written first, so on the top that is CNS involvement, HSV2 will involve the genitals. But if you read about similarly written question in which the grouped vesicles are present in a dermatomal distribution, I highlight the fact in dermatomal distribution, then the answer for the question will definitely change. Then it is going to be reactivation of chickenpox, that is herpes zoster. Another scenario that you must remember is pure CNS, where I'm describing a 18-year-old guy. Let me say he works in the city, but on the weekend he went back to his village. Now it had rained recently, so he was swimming in the village pond. This guy, 18-year-old, went back to his village, maybe to his grandparents on a holiday. He's swimming in the village pond. He's swimming in stagnant water. What he can get is something that is very shocking, that is brain-eating amoeba. This guy, when he came back after 1 or 2 days, he started having high-grade fever. He had the traditional features of frontal headache with projectile forceful vomiting. Along with that, he also developed nuchal rigidity, and you as a doctor was wondering what is going on. When you did a lumbar puncture of this guy after giving mannitol and controlling the raised ICP, the CSF of this patient was showing presence of trophozoites in the CSF. Yes guys, I'm talking about that brain eating amoeba, right? So your diagnosis in this case would be answered as Naegleria fowleri, and acanthamoeba. Obviously, when I talk about the CNS domain, I first need to talk in terms of Naegleria fowleri, or it could be acanthamoeba also written. Depending on, I mean, if both are given, then first answer is Naegleria fowleri, obviously. Do remember the fact that when it comes to fungal meningitis given to you, then it is always going to be answered as Cryptococcus neoformans, for which we shall be using India ink preparation. There's a separate discussion just inferior to these, where I have mentioned regarding immunocompromised patients, especially AIDS positive patients ending up with fungal meningitis. But since I spoke about bacterial meningitis, then about viral meningitis, and now I'm speaking about fungal meningitis, so it is important that I just jot down the name here before you. Either he can write the word Cryptococcus neoformans. I repeat that. Either it will be written Cryptococcus neoformans, or it will be written Cryptococcus gattii. Well, India ink is one of the methods that by which you can identify it, but that's not a foolproof method. So the best way would be to go in for cryptococcal reactive antigen in the CSF. I mean, if he says what is the best way for diagnosing cryptococcal meningitis in suppose a AIDS positive truck driver, then the best test that you will answer in the MCQ for this would be given by you as a CSF ELISA. Please remember, I spoke about CSF immunoblot for neurocysticercosis antigen, and now I'm not talking about immunoblot, I'm talking about CSF ELISA per se for cryptococcal CRAG, that is cryptococcal antigen to be detected. The treatment of Cryptococcus neoformans would be liposomal amphotericin B. Along with this, we shall also be using 5-flucytosine. Please remember, primary answer is not fluconazole. You will first give 2-week treatment of liposomal amphotericin B to this patient with 5-flucytosine, and then subsequently fluconazole is given to these patients for a 6 weeks duration. Please remember this fact, liposomal amphotericin B is the initial treatment. The drug of choice for this condition is liposomal amphotericin B and not to be answered as fluconazole. So these are some organism based, or I would say etiology based informations that you should be familiar for this topic.